Okay, so let's deal with wound healing today. So wound healing is a complex and dynamic process of replacing devitalized and missing cellular components or structures and tissue layers. Um, Before we go on with the slides, let's just try and review what we already know about wound healing. So in human adults, wound healing process can be divided into 3 or 4 distinct phases. Earlier, scientists referred to 3 phases: inflammatory, fibroblastic, and maturation, which also has been denoted as inflammatory, proliferative, and remodeling phases. This has been maintained by some scientists. In the 4 phases concept, they are the homeostasis phase, the inflammatory phase, the proliferative phase, and the remodeling phase. In the 3 phases approach, the homeostasis phase is contained within the inflammatory phase. So not only do scientists vary the number of phases, they also denote differences in the phase descriptors used, and they may designate phases as the homeostasis phase, inflammatory phase, proliferative phase, and remodeling phase, or they may refer to the homeostasis phase, inflammatory phase, granulation phase, and maturation phase. So therefore, certain phases have more than one name, such as the remodeling or maturation, and proliferative or granulation. So as our understanding of wound healing progresses further, further phases and sub-phases may come up. So within these broad phases are a complex and coordinated series of events that include chemotaxis or chemotaxis, and phagocytosis, new collagenesis, collagen degradation, and collagen remodeling. So in addition, we have angiogenesis, epithelialization, and the production of new glycosaminoglycans, and also proteoglycans. Proteoglycans are vital to wound healing. The combination of these biological processes results in the replacement of normal skin structures with fibroblastic mediated scar tissue. So this process produces an exuberance of fibroblastic proliferation with a resultant hypertrophic scar, which by definition is confined to the wound site. So further exuberance can result in keloid formation, and in which the scar production extends beyond the area of the original insult. The collagen is thicker, more irregularly arranged, and more often causes pain. So in a hypertrophic scar, the collagen is thinner and arranged more parallel to the wound. Furthermore, hypertrophic scars occur in all races, although less in the young and elderly persons. Hormonal changes may have impact. Keloid scarring is more often seen in non-white persons. And conversely, insufficient healing can result in a hypertrophic or atrophic scar formation. And all wounds in adults can heal with a scar. A degree of inflammation has a direct impact on the ultimate scar formation. So let's look at the types of wound healing. Although various categories of wound healing have been described, the ultimate outcome of any healing process is repair of the tissue defect. So primary healing, delayed primary healing, and healing by secondary intention are the 3 main categories of wound healing, even though different categories exist in interactions of cellular and extracellular constituents, which are similar. The fourth category is healing that transpairs with wounds that are only partial skin thickness. The categories of wound healing, let's look at them. Category 1, the primary wound healing, or healing by first intention. It occurs within hours of repairing a full thickness surgical incision, and this surgical insult results in the mortality of a minimal number of cellular constituents. The second category has to do with delayed primary wound healing. So, if the wound edges are not reapproximated immediately, delayed primary wound healing transpairs. And this type of healing may be desired in the case of contaminated wounds, and by the fourth day, phagocytosis of contaminated tissues are well underway, and the process of epithelialization, collagen deposition, and maturation are occurring. So foreign materials are walled off by macrophages that may metamorphose into epithelioid cells, which are encircled by mononuclear nucleocytes, leukocytes rather, forming granulomas. Usually the wound is closed surgically at the juncture, and if the cleansing of the wound is incomplete, chronic inflammation can ensue, resulting in prominent scarring. Let's look at category 3. A third type of healing is known as secondary healing, or healing by secondary intention. In this type of healing, a full thickness wound is allowed to close and heal. The secondary healing results in an inflammatory response that is more intense than with primary wound healing. In addition, a larger quantity of granulomatous tissue is fabricated because of the need of wound closure. And secondary healing results in pronounced contraction of wounds. So fibroblastic differentiation into myofibroblasts, which resemble contractile smooth muscles, is believed to contribute to wound contraction. And these myofibroblasts are maximally present in the wound from the 10th day to 21st day. Now let's look at category 4. Epithelialization is the process by which the epithelial cells migrate and replicate via mitosis and traverse the wound. And this occurs as part of the phases of wound healing, which are discussed in a sequence of events in wound healing. So in wounds that are partial thickness, involving only the epidermis and the superficial dermis, epithelialization is the predominant method by which healing occurs, and wound contracture is not a common component of this process. If only the epidermis or the superficial dermis are involved. Okay, so now speaking a lot about so many things, let's just look at the overview of wound healing. It's basically the amalgam of coordinated events that constitutes the process of wound healing is quite complex, and the steps in the process or in the procession of wound healing include inflammation, the fibroblastic phase, the scar maturation, and wound contracture. The wound contracture is a process that occurs throughout the healing process, commencing in the fibroblastic phase or stage. The inflammatory phase occurs immediately following the injury and starts approximately 6 days. The fibroblastic phase occurs at the termination of the inflammatory phase and can last up to 4 weeks. The scar maturation begins at the 4th week and can last for 4 years. And Analogous system depicts the four phases as homeostasis, inflammatory, granulation, and remodeling in a continuous symbiotic process. It is the phase system normally used. So the sequence of events in wound healing: so flowing tissue injury via an incision. The initial response is usually bleeding, and a cascade of vasoconstriction and coagulation commences with clotted blood immediately impregnating the wound, leading to hemostasis, and with dehydration and scab forms. An influx of inflammatory cells follows with the release of cellular substances and mediators. Angiogenesis and re-epithelialization occurs, and the deposition of new cellular and extracellular components ensues. So let's look at the initial phase, which is hemostasis. The initial injury results in an outflow of blood and lymphatic fluid. This is also the process during which the initial reparative coagulum is created. So both the intrinsic and extrinsic clotting mechanisms are activated. The intrinsic mechanism is enjoined from the thrombocytes, and the extrinsic mechanism from the injured tissues. So following vasoconstriction, the platelets adhere to damaged endothelium and discharge adenosine diphosphate, promoting thrombocyte clamping, which damps the wound. And with a short-lived vasoconstriction complete, the vessels dilate, allowing the influx of more thrombocytes and more blood cells. In this stage, one can think of the commencement of the inflammatory phase. Although some speak of a separate inflammatory phase, it commences during the hemostasis phase. Again, providing evidence of the overlapping nature of the healing compendium. So these thrombocytes, as well as the recruited white blood cells, release numerous factors to ramp up the healing process. Alpha granules liberates platelet-derived growth factor and platelet factor 4 and transforming growth factor STGF beta. The processes of inflammation, collagen degradation, and collagenogenesis, myoblastic creation from transformed fibroblasts, growth of new blood vessels, and re-epithelialization have all commenced. So these processes are mediated by a host of cytokines and growth factors, and the interleukins strongly influence the inflammatory process. Vascular endothelial growth factor and other factors enhance the blood vessels formation, and some have multiple roles, such as fibroblast growth factor 2 as FGF2, which affects not only the process of angiogenesis but also that of re-epithelialization. So vasoactive amines such as histamine, serotonin are released from dense bodies found in thrombocytes. And PDGF, I think we talked about it, the platelet-derived growth factor, is chemotactic for fibroblasts, and along with TGF beta as a transforming growth factor beta, is a potent modulator of fibroblastic mitosis, leading to prolific collagen fibro construction in later phases. So fibrinogen is cleaved into fibrin, and the framework for completion of the coagulation process is formed. Fibrin provides the structural support for cellular constituents of inflammation, and this process starts immediately after the insult and may continue for a few days. So let's look at the second phase, the inflammatory phase or inflammation. So as the hemostasis phase can be construed to consist of an early and late phase. The early phase being bleeding and hemostasis, and the late phase being coagulation. So is it also with inflammation. So while inflammatory phase commences during the hemostasis phase, the early components of the inflammatory phase is predominated by the influx of the polymorphonuclear leukocytes, PMN, and later components predominated by monocytes or macrophages. So within the first 6 to 8 hours, the next phase of the healing process is underway. The polymorphonuclear leukocytes engorging the wound. So the transforming growth factors TGF beta facilitates PMN as a polymorphonuclear leukocyte migration from surrounding blood vessels. So where this point they extrude themselves from these vessels. So these cells cleanse the wound, clearing it of debris. The polymorphonuclear leukocytes they attain their maximal numbers in 24 to 48 hours and commence their departure by 72. So other chemotactic agents are released, including TFG, FGF, TGF beta, TGF alpha, PDGF, and plasma activated complements C3A and C5A as anaphylactic toxins. So they are sequestrated by macrophages and or interred within the scalp or eschar or eschar. So as the process continues, monocytes also exude from the vessels, and these are termed macrophages. Once they leave the vessel, the macrophages continue the cleansing process and manufacture various growth factors during these 3 to 4. The macrophages orchestrate the multiplication of the endothelial cells with the sprouting of new blood vessels, the duplication of smooth muscle cells, and the creation of the below created by the fibroblast. So many factors influencing the wound healing process as secreted by macrophages, and these include TGFs, cytokines, and interleukin-1, tumor necrosis factor, and PDGF. So the third phase, that's granulation or proliferation. And this phase consists of different subphases, and these subphases do not happen in discrete time frames but constitute an overall and ongoing process. The subphases are fibroplasia, matrix deposition, angiogenesis, and reepithelialization. In days 5 to 7, fibroblasts have migrated into the wound, laying down new collagen of the subtypes 1 and 3, and early in normal wound healing, type 3 collagen predominates, but later is replaced by type 1. Collagen is a precursor of all collagen types and is transformed within the cell's rough endoplasmic reticulum, where proline and lysine are hydroxylated. The disulfide bonds are established, allowing 3 collagen strands to form a triple left-handed triple helix termed procollagen. As the procollagen is secreted into the extracellular space, peptidases in the cell will cleave terminal peptide chains, creating true collagen fibrils, and the wound is suffused with GAGs and fibronectin produced by fibroblasts. These GAGs include heparan sulfate, um, hyaluronic acid, chondroitin sulfate, and keratan sulfate. Proteoglycans and GAGs that are bonded covalently to the protein core, and to the protein core mainly contribute to the matrix deposition. So angiogenesis is a product of parent vessel offshoots, and the formation of new vasculature requires extracellular matrix and basement membrane degradation, followed by migration, mitosis, and maturation of endothelial cells. So basic FGF and vascular endothelial growth factor are believed to modulate angiogenesis. Re-epithelialization occurs with the migration of cells from the periphery of the wound and adnexal structures, and this process commences with the spreading of cells within 24 hours. So division of peripheral cells occurs in hours 48 to 72, resulting in a thin epithelial cell layer which bridges the wound. So epidermal growth factors are believed to play a key role in this aspect of wound healing. The succession of the subphases can last up to 4 weeks in a clean and uncontaminated wound. The fourth phase, the remodeling or maturation. So after the third week, the wound undergoes constant alterations known as remodeling, which can last for years after the initial injury occurred. The collagen is degraded and deposited in an equilibrium producing fashion, resulting in no change in the amount of collagen present in the wound. The collagen deposition in normal wound healing reaches a peak by the third week after the wound is created. The contraction of the wound is an ongoing process, resulting in part from the proliferation of the specialized fibroblasts termed myofibroblasts, and which resemble contractile smooth muscle cells. So wound contraction occurs to a greater extent with secondary healing than with primary healing, and maximal tensile strength of the wound is achieved by the 12th week. The ultimate resultant scar has only 80% of the tensile strength of the original skin that it has replaced. So let me summarize all these things I've talked about. So the process of trying to understand wound healing traces back to ancient times and has continued to be investigated. Interest grew in the 90s. By 1960, it was understood that wound healing could be decreased up to 50% if appropriate dose-dependent settings are created. And continuing from that time, there has been an ongoing expansion to not only understand the vast array of intrinsic and extrinsic factors of wound healing, but also the intracellular, extracellular, molecular, biochemical processes and interactions that facilitate healing. The process of wound healing constitutes an array of interrelated and concomitant events, and understanding these processes and effectors of these processes continues to expand. Let's look at some few controversies. Okay. So future advances in wound healing will mainly focus on affecting the agent that influence the processes involved in the repair of the damaged tissue, and laser techniques non-laser techniques and other modalities are being explored to enhance the proliferation of the cells and the migration of the cells and the acceleration of the healing of wounds. The human cell conditioned media developed in embryo logic-like conditions has been shown to improve healing times in post-laser facial skin. Fetal tissue can heal scarless due to the unique characteristics of fetal epithelial and mesenchymal cells and functioning of the fetal immune system. The inclusion of transforming growth factor beta 3 during the healing of wounds in adults can be beneficial. The TGFs and beta 1, beta 2, and beta 3 all have significant roles in wound healing, and a simple addition, subtraction, or ratio of these growth factors may not be fully explanatory for scarless healing. Hyperbaric oxygen has also been used to promote healing. Agents such as platelet-rich plasma and erythropoietin are modulators that have a positive effect on tissue regeneration and have been used successfully to enhance the healing of wounds. In a study of wound healing in patients who had undergone some maxillofacial surgery, they found that some individuals to whom the PRP, the platelet-rich plasma, was applied during surgery demonstrated an earlier appearance and increase in fibroblasts, macrophages, and collagen fibers than the controls did. Moreover, on post-operative days 1 and 5, wound fluid in the treatment group had a greater concentration of interleukin-1 beta and TNF alpha than that of the control group did, and manifestation, according to the investigators, of PRP's effects of healing's inflammatory and granulation phases. Okay, so there's several studies have been done on this, and okay, let me talk about a few of the studies too. So a study by Mizura et al. Suggests that PRP promotes wound healing by activating a complex of growth factors and adhesion receptors, so that cell proliferation, migration, and collagen biosynthesis are stimulated. So according to the study findings, activation of the epidermal growth factor receptor via PRP brings about peptidase D dependent proliferation of human keratinocytes. So a study by Hofherrlin et al. Suggests that although peptide growth factors are considered essential to the wound healing properties of PRP, the lipid fraction of PRP also plays an important role in this by aiding in the proliferation and migration of primary adult human dermal fibroblasts and overcoming the suppression of fibroblast proliferation by chronic wound fluid. So nutritional factors also are critical for proper wound healing. Improvement in the nutritional status of adults correlates with enhanced wound healing. Honey has been shown to be less beneficial in wound healing despite its use since early times, and has even caused delayed healing in certain types of wounds. A literature review by Ju et al. Found evidence that treatment with honey causes partial thickness burns to heal more quickly than they would with conventional management, and that infected post-operative wounds may heal more quickly with honey than with antiseptics and gauze. but the investigators determined evidence for honey's effects on other wounds to be low and very low quality. The literature review by Bates, utilizing narrative reviews, clinical trials, animal studies, indicated that medications with the greatest risk of negatively affecting wound healing and skin integrity include antibiotics, anticonvulsants, angiogenesis inhibitors, steroids, and non-steroidal anti-inflammatory drugs. The drugs that may aid wound healing, on the other hand, include ferrous sulfate, insulin, thyroid hormones, and vitamins. Okay, a rat model pine back from the Turkish spine increased the rate of wound healing. Alloarborescence has enhanced healing properties when compared to aloe vera. Appropriate neurological stimulation is also important in the healing of wounds. In a report, it was shown that capsaicin-induced nerve damage resulted in small fiber neuropathy and was associated with slower healing in shallow wounds, not deep wounds. Reparative strategies involving engineered tissue matrices, either exogenous or endogenous, have also been used. With time, cells continue to be a new frontier of research in the armamentarium of wound healing strategies. And these still exist. There are still controversies of the use of fetal stem cells. And stem cells, in particular, adipose-derived stem cells, have been shown to ameliorate wound healing, and also continue research in these areas appears promising. Exogenous mesenchymal derived stem cells, commonly obtained from bone marrow but available from other sources, are being used in the setting of non-healing inflammatory wounds. Third trimester, human fetal, placental, chorionic stem cells did not compare favorably with first semester ones in promoting wound healing. However, the first and more recently mid-trimester amniotic stem cells, when treated using valproic acid, obtained pluripotentialism, or very promising. Okay, so let's go back to what we're talking about. Wound healing is basically a cut or a break. A wound is a cut or break in the continuity of any tissue caused by an injury or operation. And like I said, a wound is basically an injured tissue, and it can either there is either a disruption or destruction of the tissue architecture. Wound healing is defined as a replacement of damaged tissue by living tissue. There are some terms that you have to know about. Basically, repair refers to replacement of damaged tissue with fibrous tissue, which mainly occurs in man. Regeneration refers to new tissue, as when new tissue is morphologically and histologically similar to the damaged tissue. Regeneration is said to be perfect in lower animals, for example, earthworm, but imperfect in man, for example, healing in viral infections. The resolution occurs when tissue loss is minimal and no new tissue is formed. The end result is essentially the same tissue as the original, for example, healing in lobar pneumonia. The types of wounds, it can be closed or open. So closed wounds, we have the blister, contusion, bruise, ecchymosis, and opened, we have abrasion, puncture wound, laceration, penetrating wounds, perforation, avulsion wounds. Let's look at the other types. You have like I talked about, the three basic types of healing: the healing by primary intention, secondary intention, and tertiary or delayed primary intention. Okay, so let's go on. So healing by primary intention, all the layers are closed and the incision that heals by first intention does so in a minimum amount of time, with no separation of the wound edges and with minimal scar formation. The healing without is healing without complications, and there is minimal new tissue. Okay, so let's go on to the next: healing by secondary intention. The deep tissues are closed, but the superficial layers are left to heal from the inside out, and the wound surfaces are not approximated. The defects filled by granulation. The defect is filled by granulation, and the healing uh, by secondary intention is appropriate in cases of infection, excessive trauma, and tissue loss or imprecise approximation of tissue. Let's look at healing by tertiary intention. This is a process. This is the healing process occurring in a wound that has undergone delayed primary closure. The delayed primary closure is suturing a wound 4 to 6 days after the onset. It is the healing occurring in the wound that has undergone delayed primary closure. So in healing contaminated wound, closure is done 4 to 5 days later when the healthy granulation tissue would have been present. Okay, so this is a picture of healing by secondary intention. You can see there are a whole lot of damaged tissues over here, and I think this is a great picture. Okay, so there's another picture. That's also healing by secondary intention, and this one too had to do with the toe. Okay, so the causes of tissue injury, we have it could be mechanical. That's from trauma. So something hits you, or you hit something. The major cause of injury. That's a major cause of injury. So RTA, road traffic accidents, workplace, home assaults too could lead to that. And chemical agents, so strong acids, alkalis, and other caustic and corrosive chemicals could result in that. Coagulates tissue proteins and also can cause necrosis. So biological agents like microorganisms, pathogenic microorganisms could lead to that. So they produce toxins that can cause necrosis of the skin, and radiation energy too could lead to that. So various forms of radiation, we can talk of X-rays, atomic, nuclear, and electrical energy, intense heat or even cold cannot cause these damaged tissues too. The three phases of wound healing are inflammatory phase, the proliferative phase, the maturation or remodeling phase. And you can see from this chart that at the inflammatory phase, the neutrophils have the highest, you get the highest numbers in neutrophils, and that's from day 0 to 2. And the macrophages, that has a blue color, the fibroblast has a green color, the lymphocyte is the orange-like color. Okay, so you can see the inflammatory phase, the proliferative phase, and the maturation phase. Normally, fibroblasts move on to the maturation phase even at day 14. Okay, so let's go on. The exposure of the subendothelial collagen to platelets. So the platelets aggregation and activation of coagulation cascade. Okay, so that's basically the step. So there's exposure of the subendothelial collagen to platelets, and when that happens, platelets aggregation and activation of the coagulation cascade continues, and the fibrin clot provides a provisional ECM for extracellular matrix for the cell migration. So serotonin and histamine causes vasodilation and vascular permeability. The neutrophils in the wound phagocytose the bacteria by foreign particles. The macrophages appear in the wound within 24 to 48 hours. The macrophages recruit and activate other cells, and this leads to regulation of the cell proliferation. There is regulation of the cell proliferation, matrix synthesis, and angiogenesis. Okay, so that's basically a picture with the inflammatory phase. See the macrophages, the fibrin claws, you see all the various types things involved over here. So let's go on to the proliferative phase. So here, okay, so epithelialization, angiogenesis, and provisional matrix formation occurs. And this begins when the wound is covered by epithelium, so days 4 to through to 14. The production of collagen is a hallmark, days 7 to 6 weeks. So wound contraction, so actual contraction with the pulling of the edges towards the center, making the wound smaller, and myofibroblasts contractile properties. The myofibroblasts, they have contractile properties, so surrounding skin stretches, stretched and thinned, and original dermal thickness is maintained, but no hair follicles or sweat glands are formed. There's a wound healing, and line. It corresponds to the line of cleavage in the skin and is related to collagen fiber arrangement. So vertical in limbs and horizontal in the trunk. And the scar along these lines are stronger than, and then they have better cosmesis than those across the lines. So the factors affecting wound healing, we have age, malnutrition, severe constitutional diseases, and drugs. And the local factors. Okay, so local factors, basically oxygen is the most important wound nutrient. So hypoxia impairs collagen synthesis. Blood supply can affect wound healing. Wound infection delays healing. Depends on the destructive powers of the organism. Prolonged inflammatory phase interferes with epithelialization, contraction, and collagen synthesis. Also, foreign bodies to affect wound healing. The surgical technique. So wound edges are not correctly. If the wound edges are not correctly opposed, and there is rough handling of tissues, excessive tension in the wound from tight tissues sutures, also radiation to an endothelial cell injury, impair inflammatory response. Okay, so for some special tissue study has its own category. So finally, let's look at skin replacement. So all wounds require coverage to prevent evaporative losses and infection. Conventional skin grafts is usually done. We have split or partial skin grafts, the partial thickness graft, and the flaps. Okay, so that's basically something about wound healing. Okay.